Hi everyone, we're going to talk about common injuries in Chapter 40. As we begin to learn more about common injuries, it is important to note that unintentional injuries are the leading cause of death and in little ones and can account for over 9 million non-fatal injuries. With these injuries, there's about 8,500 deaths and over 8.7 million emergency department visits each year for kids between the ages of 1 and 19. Prevention is such a big part of what we do that it's important for us to help the parents of the peds that we see in practice, guide them in providing a safe environment that's appropriate for their children. When you're providing education for injury control, it's important to be more specific than non-specific. For example, teaching the child and the parent how to size a bike helmet versus saying that they always need to wear a helmet when they ride their bike. Education can be given as written materials, audiovisual presentations, counseling, or one-on-one interactions with the parent and the child, but it's important not to give too much information and then provide reinforcement and repeat this information in subsequent visits. So there are three main components that are needed in managing a child that has had an injury. These include gathering an appropriate history, identifying how the injury occurred, and then finally performing a thorough physical exam. If the injury is felt to be life-threatening or you're seeing a deterioration in the child's condition, doing a trauma severity assessment must be performed immediately. And there's more specifications on that on table 40-0 in the book. And it's broken down into mild, moderate, and severe, and we'll tell you a little bit more about some of the key findings that you will find with that. If you're seeing a child in your practice that has been injured, it's important that you should make your first assessment within the first 5 minutes of initial contact. This assessment should include their respiratory status, making sure that their airway is patent, making sure there's good circulation to the extremities, doing vital signs, gathering a brief history, including allergies, meds, past medical history, and any events that could be associated with the injury. Doing a rapid assessment of organ systems such as cardiopulmonary, if the child needs to be better maintained and is having issues with airway. Once the child is stabilized, a second assessment would take place with a more complete physical exam, and then if necessary, doing labs and x-rays. As practitioners, it is important to us to be aware and keep it in our differential diagnosis that what the child presents with could be a non-accidental trauma, such as a physical abuse, and if the explanation that's given by the caregiver does not match up with the injury. So we're going to start with talking about some trauma to the skin and the soft tissue. And so abrasions are superficial skin injuries that are often the result of a fall or when the skin has had friction that involves epidermal trauma. The depth of the skin involvement will depend on the force and the friction during the encounter of the injury. And the most serious form of abrasion is called an avulsion, and that's trauma that results in the loss of all three layers, the epidermal, the dermal, and the subcutaneous layers. It's important that we get a good history and learn as much as we can about the cause and the type of injury, if there's been any foreign objects that could possibly be in the wound, and more about the dirt at the scene. On physical exam, you're going to want to assess the area and determine the extent of the abrasion and if there's presence of any dirt, grime, or other foreign bodies, such as tar possibly. You'll note that the skin may appear to be scraped off and may be oozing serous fluid and blood. There may be increased pain, swelling, redness, warmth. And if there's any red streaking, this could be an indication of a secondary infection. It's important, if the injury is located on an extremity, to be sure to assess the tissue and circulation above and below the injury. Management of abrasions requires appropriate first aid care to help prevent infections. So the area will be cleansed with copious amounts of water or normal saline. You're going to want to debride the area and remove any foreign bodies. The area can be scrubbed with a surgical soap or an antibacterial cleanser using some wet gauze. It's important that iodine, alcohol, and peroxide not be used in open wounds, as this can damage the underlying tissue and prevent or slow down healing. If there's loose skin at the edges, this can be removed with sterile scissors. Foreign bodies can be removed with tweezers, and if tar is noted, then petroleum jelly can be placed on the wound, and then that often will help bind with the tar so that when it is irrigated and washed out again with water or saline, should help remove that. Depending on the extent of the abrasion will determine whether you'll leave it open to air or whether it'll require dressing. Larger abrasions should be covered with a sterile, non-adherent dressing, and an antibiotic ointment such as bacitracin may be applied, especially to abrasions on the knees or elbows, as this will also help prevent cracking or reopening of the wound as it's over a joint and there's the continuous movement. These areas need to be washed at least every 24 hours and a fresh dressing and antibiotic ointment, if being used, applied until a protective scab is formed. It's also important to educate the parents and the child of signs and symptoms of infection. This is a great time to assess for tetanus prophylaxis. So if the child has not received a tetanus immunization within the last 5 years, or if the wound is significant, then a tetanus shot would be appropriate. Next, let's talk about puncture wounds. So these result from the penetration of different layers of the skin and underlying tissue depending on the object that has caused the injury. They are typically classified as superficial or deep. Some common things that can cause a puncture wound include glass, wood splinters, toothpicks, needles, nails, metal, staples, thumbtacks, and bites. Most of these wounds heal without any issues, but there can be complications by infection that could lead to a cellulitis or a fasciitis or a soft tissue abscess. Staph aureus and beta hemolytic streptococci are normal flora found on our skin, but they are often common causes of secondary infections and puncture wounds. Pseudomonas also colonizes on the rubber soles of tennis shoes, and if there is a plantar puncture wound from someone stepping on something and it goes all the way through the shoe, it's important to assess for infection with this. There is potential that osteomyelitis can occur if the puncture wound penetrates into the bone or joint. So when you're assessing for the risk of infection from a puncture wound, it's important to take in the location and the depth of the wound and the presence of the foreign object. If there's signs of infection, it's important to culture. We talked previously about the Tdap. Antibiotics that may be used if you're concerned about infection could be augmentin, cephalexin, clindamycin, and Cipro. If there is concerns for osteomyelitis or osteochondritis, some of those signs and symptoms could be extension of pain and swelling around the puncture wound. There could be specific point tenderness over the bone. There could be fever, increased redness, and decreased use of the affected extremity. As always, important to get a good history and get the date and the time of the injury and how the wound occurred. You need to have identification of the penetrating object and the estimated depth. What kind of condition was the penetrating object in? Was it clean? Was it dirty, jagged, or smooth? Whether the parent or child feels that the foreign object was completely removed. It's important to know what their current immunization tetanus status is, and if there are any other medical conditions that can increase the risk for infection. You want to be sure and do a good physical exam to note circulation, movement, and sensation in the area around and next to the injury. You need a good light source. Diagnostic studies may be needed if there's suspicion for a retained foreign object, if there's increased pain at the site of the wound, if the penetration was into a joint space or in the bone or growth plate, if the puncture site has signs of infection, and if the penetrating object was a nail. Management would include cleaning and debridement of the area. Depth of the wound will determine how extensive cleaning of the wound will be. Most simple, uncomplicated puncture wounds do not need antibiotics, but if there are concerns for infection, the puncture could be a result of a cat bite, or if the wound is deep and contains debris, antibiotics should be part of the treatment plan. Those antibiotics for puncture wounds would include amoxicillin, clavulanate or cephalexin. Clindamycin could be used with children that are allergic to penicillin. If there's concerns for MRSA and there's the ability to culture the wound, then treating with Bactrim or clindamycin is recommended until sensitivities are returned, and treatment would be prescribed for 7 to 14 days depending on the severity of the infection. Sorry, I had an interruption, and I'm not for sure if I said this, but if antibiotics are started, it's important to have a recheck appointment in approximately 42 hours to assess how outpatient therapy is going. Depending on the extent of the wound and the foreign body, and if there's drainage, will determine the extent of debridement that is needed. But if there is severe infection secondary to the puncture wound, such as a septic arthritis or an osteomyelitis, then surgical debridement may be needed with hospitalization and parenteral antibiotics. Management at home would be cleansing the wound a couple of times a day with warm water and soap, and then applying an antibiotic ointment such as bacitracin, covering the wound, and observing for any signs of symptoms of infection. Next, let's talk about ingrown nails and nail hematomas. So the official name for ingrown toenails are onychocryptosis, and these and nail hematomas are common in primary care. We all know that ingrown toenails can be caused by several different factors, including how the nail sits on the nail bed, the fitting of the shoe, any trauma to the nail, and most importantly, improper toenail trimmings. The big toe is most often impacted. And the mechanism is that an edge of an ingrown toenail grows into the skin fold. So let's talk briefly about management of each of them separately. For the ingrown toenail, for the area of skin that is causing or working its way in the area of the nail that's working its way into the skin, you can raise that slightly with a little bit of cotton, and that will help change the growth curve of that nail. And it's important to educate your patient that the cotton needs to be changed daily to prevent infection. Soaking the foot in warm water with a mixture of Epsom salts for about 20 minutes 3 times a day will help keep the nail soft and prevent infection. Systemic antibiotics are rarely needed, but if the persistent ingrown toenail continues, you may need to refer to a podiatrist. If you feel that you need to drain that, it's going to be important to decide whether there needs to be a nerve block done. If you're going to try to relieve the hematoma, it's important to wash the nail with saline solution and then clean with chlorhexidine or alcohol. Uncomplicated hematomas can be drained easily in the office. You would make 1 or more holes in the area of where the hematoma is, either with a portable heat cautery device or the end of an untwisted end of a paper clip is what the book suggests. It's important to note that the holes are large enough to drain the hematoma. Antibiotics are generally not needed. Management at home includes assessing for signs and symptoms of infection and to return if there's concerns for that. It's important to let the parents and the child know that the hand needs to be soaked 3 times a day with an antibacterial soap in the water until the drainage has stopped and that the underlying skin starts to heal. Next, we're going to talk about lacerations. So lacerations are deep cuts to the skin that can be caused by a variety of mechanisms and are most often seen on the face, scalp, and hand. It's important to get a good history and do a physical exam, and I'm not going to go over the details of those as they are very common with some other history and physical exam components that we've talked about. Management is going to include how you're going to manage the laceration. There are different thoughts on when is your window of opportunity to close a laceration. But wounds that are considered a low risk for infection, such as a knife wound, can be closed even up to 12 to 24 hours after the injury. Some other things to consider is most facial wounds need to be closed within 24 hours of the injury. The risk of infection is inversely related to the blood flow to that part of the body where the laceration is. If the area doesn't have as much blood flow, then there's a higher risk of infection. Contaminated wounds and crush wounds in kids who are immunocompromised or at a high risk for infection should be closed within 6 hours. Any laceration from an animal, human, or barnyard animal should be left open for healing, where granulation will occur in the center of the wound and work out. It's important to decide what type of anesthesia that you want to use. And doing these procedures would be something that you've taken a special class for, you've received a lot of mentoring on, so we're not going to get into a lot of detail on the types of anesthesia. Hair does not generally need to be removed. If there are areas in the way, it is better to clip rather than shave. Cleansing of these wounds would require irrigation to reduce any form of contamination and prevent infection. A general rule of thumb is that you use 50 to 100 milliliters of normal saline per centimeter of the wound or the laceration. Table 40-2 talks about suture and staple removal guides. So based on where the closing device is, determines how long it should be there based on where it is. So if you have sutures to the face, the length of time for removal could be anywhere from 3 to 5 days, where if it's over a joint, you would remove it in anywhere from 10 to 14 days. Instructions for care at home would be that the patient could shower 48 hours after the sutures are in place without any risk of infection. It's important to keep the area dry. Important that they know signs and symptoms of infection to call about, redness, swelling, discharge, or pain, and give instructions on cleansing and bandaging of the wound. Next, let's talk briefly about burns. So the CDC states that there's approximately 300 children from birth to 19 that are treated in emergency rooms for burn-related injuries, and 2 children die from burns or burn complications in the United States daily. Common causes of burns include grills, hot soups, water, curling irons, house fires, and appliances. Younger children tend to sustain more scald injuries from steam or hot water, and older children incur burns more often from flames and direct contact with fire. So just to review, a burn is an injury to one or more layers of the skin that can cause varying degrees of damage. They are classified by the depth of the injury and the percentage of the body surface area that's been involved. The classification for burns has changed from first, second, and third degree to superficial that are either partial or deep, and then full thickness. So just to review, superficial burns involve only the epidermis. Partial thickness involve the epidermis and the dermis to a certain degree. And then full thickness are burns in which the epidermis and the dermis are completely destroyed. You need to be sure and obtain a detailed history. And then on the physical exam, it's very important to first assess for airway, assess for any inhalation injury that may cause upper airway edema. Airway complications should be suspected if there's been loss of consciousness, a death of another victim, presence of facial or neck burns, and any burn or soot debris over the nasal passages or in the oral cavity, or if there's a presence of cough, wheezes, or crackles. On table 40-3, there is a guide on how to determine the BSA effect. Diagnostic studies may include a CBC, a chemistry panel, a urinalysis, pulse ox, arterial blood gases, and cardiac monitoring. After all of that is obtained, it's important to determine whether the child needs to be admitted based on the factors that you've gathered in the assessment and physical exam. If it's determined that you're able to manage the burns in the primary care setting, there is a great box on 40-1 that gives more detail on how the management of superficial and partial thickness burns would occur. We've talked a little bit about these things. On your patient and parent education, as the burns are healing and the skin is regrowing, it's important to provide skin sunscreen protection. It's important to review home and environmental safety concerns such as smoke detectors, hot water heater temperatures, never leaving cooking food on the stove unattended, and creating a family fire escape plan. So for this slide, as I mentioned previously, review box 40-1. Let's talk next a little bit about contusions and hematomas. A contusion, also known as a bruise, is an injury in which the skin is not broken but there's been trauma to the area. Hematomas are localized collections of blood into the tissue. It's important to do a good history and physical on where the hematoma or the contusion is. With these injuries, it's also important to expand the differential diagnosis, especially in the hematoma realm. Could there be some blood-related issues going on, such as hemophilia, von Willebrand's disease, purpura? There is a condition called myositis ossificans, which is a complication of contusions. Management includes the RICE acronym that we discussed in class on Tuesday. So rest, ice, compress, and elevate. It's also important to provide appropriate pain management, whether that be with Tylenol, and depending on how extensive the injury is, if any narcotics needed to be added, or a non-steroidal anti-inflammatory such as ibuprofen. Typically, NSAIDs could be beneficial in the first 2 to 3 days of the injury. After the first 24 to 48 hours, warm compresses may or may not be beneficial to the child. My rule of thumb is, after the ice, use what makes the area feel better. So if warm compresses make it to feel offer better symptom management, then use warm compresses. If ice continues to help, then use ice. Avoidance of exercises for about 5 to 7 days will help the area to heal better. It's important to explain to the parents that there's going to be skin color changes as the ecchymotic area gets absorbed into the skin, and for them not to panic for the change in color from purple to green and how it can spread to different tissues. Return to the child's normal activity will be determined by the degree of the injury and how well the symptoms resolve. Next, we're going to talk about bites, and this is going to be a little lengthier of our typical 20 minutes, but there's only a few more slides, and I'd rather go a little bit longer so you just have one video or audio to listen to for chapter 40. So children can be bitten by a variety of different things, such as pets, stray animals, or humans, especially other children. Most animal bites are to the head and neck in infants and very young children, and to the upper extremities in older children. And then, in contrast, most bites caused by other young children occur on the upper extremities. Important to get a good history and physical. Ask about the circumstances surrounding the bites, the type of animal. Was it domesticated or feral, provoked or unprovoked? The wound should be assessed for the type, size, and depth of the injury. Look for any foreign bodies. If the bite is on an extremity, assess for range of motion and sensory perception on that extremity. A diagram of the injury to be included in the child's chart is very beneficial, and of course, if possible, taking photographs to document the injury. Aerobic and anaerobic cultures should be obtained for wounds showing signs of infection, and an x-ray should be obtained if there's concerns that the bite could have impacted the bone or joint. Management includes both physical and psychological care of the child, and you need to assess for the need for a tetanus booster and if rabies prophylaxis is needed. And based on the situation and your locale, you may need to consult local animal control or the public health department. Depending on the depth and the width of the bite, you may need to administer analgesia. The area is going to need to be debrided and assessed for tissues that are not viable and any foreign matter. Again, we do that with normal saline and irrigate it for this type of wound with high pressure. If it is an isolated puncture wound, it doesn't need to be irrigated. Instead, to soak in a dilution of tap water and some betadine. Prophylactic antibiotics are used for human and cat bites and would be given for 3 to 5 days. These would include Augmentin, Bactrim, azithromycin, or Rocephin. There are various thoughts on whether bite wounds should be closed or whether they should be delayed closure or allowed to heal from the inside out. So I encourage you to read that section in the book under management. Education, it's important to teach children to avoid stray animals and to be cautious around domesticated animals and not to tease or provoke. Parents should offer supervision when kids are playing with pets. And then report any stray animals promptly to your animal control office. So the next thing we're going to talk about is Hymenoptera, and these are bees, hornets, yellow jackets, fire ants, and wasps. And they have some antigens in their venom that can cause reactions. It's important to do a good history and a physical exam to assess what the area where the bite looks like, if there's been any severe reactions including anaphylaxis, and it's important to assess for hives, difficulty breathing, wheezing, difficulty swallowing, changes in speech. Management includes for a mild local reaction, if the stinger is visible, then to use a straight edge sharp object such as a knife blade or a credit card to flick off the stinger. Applying cool compresses, administering some antihistamines, and then any steroidal cream may help reduce the itching. If there's a moderate to severe reaction, these may need to be treated with, on top of antihistamines, some corticosteroids and possibly some inhaled bronchodilators. If there's been an anaphylactic reaction, then it's important that they be transported to the ED as quickly as possible. The use of epinephrine can be used during these situations, and it's important to feel comfortable with your dosing, so I encourage you to review that, as is based on a milligram per kilogram. These doses can be repeated every 5 to 15 minutes if the patient is having recurring or refractory symptoms. Most patients will respond in 1 to 2 doses. If giving antihistamines, it's important to give immediately, and then depending on which one you're giving, you can repeat up to every 6 hours for up to 3 days. But antihistamines are not used in place of the epinephrine. They're used in conjunction with. And we know that there are 2 types of antihistamines, type 1, which is an H1 blocker, and type 2, which is an H2 blocker. And we know that giving both of these type of blockers is shown to help relieve histamine mediated symptoms of them better than just the H1 blocker. So for example, you might give Benadryl and then also give Zantac as an H2 blocker. So after being bit by one of these, if a child developed any life-threatening respiratory symptoms, it's important that they be referred to an allergist. Okay, next let's talk briefly about mosquitoes, fleas, and chiggers. Management of these bites includes controlling the itch and some cool compresses, some topical corticosteroids such as hydrocortisone may help with that, calamine lotion, and oral antihistamines. If there's concern that there is an embedded chigger, this can be withdrawn by covering the insect with alcohol, mineral oil, or nail polish. If itching persists, using some colloidal oatmeal baths is beneficial, such as the Aveeno products. And if there's concerns for fleas, then the treatment of animals and the cleaning of carpets, beddings, furniture, etc. Kind of like what we discussed in class for lice. Prevention is key, and the use of insect repellents are usually generally very effective. Wearing protective clothes and wearing neutral colored clothes. It's important to avoid scented products such as hairspray, powders, soaps, lotions that might attract insects as well. Okay, let's talk real quick about ticks. They can be found in grasses, shrubs, vines, and brush. They can also be found on animals and humans. The female tick can suck blood from the skin and then can inject a toxin while sucking the blood. And this is one of the ways that Lyme disease is transmitted. Most tick bites occur in the early spring to early fall. Rocky Mountain spotted fever can occur throughout the United States, but it's most common in the southeast and the central regions. So in your assessment, it's important to know if there's been a recent tick bite or exposure to tick habitat. Often most individuals have no recall of tick bites, and less than 50% of patients with Lyme disease remember being bit by a tick. Important to do a thorough physical exam. I encourage you to review the specifics of that in the book. The best thing that can be done to manage tick-borne infections is to prevent them. So wearing protective clothing is very important. And when a tick is found, to remove it as soon as possible to prevent tick-borne illnesses. That removal needs to be complete removal. If fragments are left, then local symptoms can continue to occur. Other ways to prevent being bit by ticks is to avoid areas that are infested with them, avoid sitting or leaning on trees or logs, wear protective clothing, use DEET-containing insect products, and inspect kids for ticks when they've been outside playing. And if they're on a hike, to check for ticks every 2 to 3 hours. It's important to check the scalp, the hairline, the neck, behind the ears, armpits, legs, back of the knees, and the groin. After you've been out for a hike, taking a brisk shower will help remove any ticks that are not firmly attached. Okay, spiders and scorpions. Most spider bites don't cause a lot of issues. They may just cause some local reactions. And most spiders avoid humans, but there are two main spiders that can cause complications in the United States, and that's the black widow and the brown recluse. And the black widow can be identified by that it's shiny black with a red or orange hourglass marking on its underside. The brown recluse is the most dangerous, and it has an oval light fawn to dark chocolate covered body with dark brown violin-shaped bands extending from its eyes down its back. It's important to assess for any known history of spider bites or activities in areas where these spiders are found. We're not going to get into it now, but in the book, review the progression of what might occur after the spider bite on the physical findings for both the black widow and the brown recluse and scorpion bites. The management of these cases is determined whether it's been a venomous spider, and based on that we'll determine appropriate medical care. With the black widow, we know that there can be mild pain and redness, severe muscle cramping, sweating, irritability, and some CNS. These wounds need to be cleaned with soap and water, and then have some administration of pain meds, nausea meds, and muscle relaxants, and then tetanus prophylaxis that's needed. With the brown recluse spider, we know that there can be localization of where the bite is to a gangrenous area with eschar. There can be lymphanginitis in the extremities. There can be systemic nausea and vomiting, chills, fever, malaise, muscle aches, and pains. These wounds tend to heal without too much issue after, but you will note the necrotic areas. They require tetanus prophylaxis, pain medicine, the use of ice or cold compresses, and elevation. If there's extensive necrosis, a surgical intervention may be needed. Okay, snake bites. There are over 600 different species of venomous snakes that can cause anywhere from 100,000 to 125,000 deaths per year. On our history, it's helpful to assess as much as you can about the report of the snake bite, determine the type of snake. On physical exam, you're trying to determine features that might indicate the presence of venom and what is going on with that. So review that in the book. If it's a non-venomous snake, you're simply going to clean the wound, give your tetanus prophylaxis, and what might be needed for pain management. If there's concerns for a secondary infection, then you would give antibiotics for approximately 5 days with an augmentin. If there's uncertainty about the identity of this snake, then it's important to contact poison control and observe for these symptoms for at least 3 to 4 hours. Treatment for the venomous snake will be based on the type of snake that it is. For parents, prevention is the most important. If a bite has occurred, then first aid measures are the next step. Removing the patient from the area, splinting the affected extremity, removing any jewelry, watches, or constrictive clothes before swelling sets in. Not to elevate this extremity. Not to give any alcohol or caffeinated beverages. Cleanse the wound with soap and water. Don't apply a tourniquet or any compression dressings. And transport immediately to the nearest medical facility. We don't have slides here for them, but let's talk briefly about heat and cold injuries. Frostbite is when ice crystals form in the soft tissues as a result of exposure to the cold. We know that this freezing can impair circulation, and there can be constriction and vasoocclusion of vessels. Important to do a good history and physical. The area may be cold. As it's warming up, the skin may turn red, then appear pale or waxy. On rewarming of the tissues will give more information on the extent of the frostbite. With deep frostbite, you may see cyanosis or mottling, erythema, swelling, numbness, vesicles, or gangrene. Table 40-5 gives the different levels of frostbite. Management of severe frostbite should be managed by medical specialists. But for mild frostbite, cover the affected areas with other body surfaces and warm clothing to help rewarm, avoid pressure or rubbing the affected area. Pain as medicines as needed. Also applying aloe or oral ibuprofen to help decrease inflammation. With hypothermia, this is when the body temperature falls below 95 degrees. A good H&P for mild hypothermia. Remove the child from the cold environment, replace any wet clothing, provide warm liquids if the patient is conscious and able to drink. Sometimes placing the child in a warm bath can be effective. As the body cools further, it's not able to generate heat, so other sources may be and must be provided, such as warm blankets, hot water bottles, heat lamps, but those all need to be used with caution. And if those are not available, then skin-to-skin contact with another person with a normal temperature with a sleeping bag or a blanket will help with the warming process. Children with severe hypothermia will need to be in the hospital setting, and we're not going to go over that. Hyperthermia is increase in body core temperature. You can have heat cramps, exhaustion, and heat stroke. The cramps can be uncomfortable and can be caused by electrolyte depletion. Heat exhaustion is caused by excessive sweating with not enough fluid intake. And heat stroke is a core temperature greater than 104. A good history and physical is needed. And then for heat cramps, you want cooling measures, rest, and oral replacement of electrolytes. For heat exhaustion, you want rest in a cool and well-ventilated environment, oral replacements, and if weak or if there's impaired level of consciousness, then IV electrolytes. For a heat stroke, The focus is on cardiovascular support and normalizing body temperature. Patient education is important, and keeping the child well hydrated, making sure they're well rested with good nutritional intake, and providing appropriate clothing such as sunshades, hats, and light reflective clothing. And then also regulating outdoor activities when it is that hot out. And lastly, motor vehicle trauma. It's important to position young children in rear seats and use correct child restraint systems. And then also educating the parent on the different seats based on the different weights. Other pedestrian injuries could be found using bikes, skateboards. It's important during a well child exam to review preventative measures, helmets, elbow guards, knee guards, etc. that will help with certain injuries. All right, I think that'll do it for this chapter. It went on much longer than I thought it, and I apologize, but we'll end this one out. Thank you.